Good day. AHCA NCAL is a provider association in Washington, D.C., representing more than 14,500 facilities providing care in over 1 million skilled nursing facility beds and over 280,000 assisted living beds. This represents the majority of SNFs and a large portion of AL communities nationwide. Approximately 1.5 million Medicare beneficiaries receive Part A SNF benefits each year. About 2/3 of these patients admitted from the community return home after a short post-acute stay. The patient-driven payment model has provided new opportunities for researchers to advance the understanding of the value of rehabilitation care in today's rapidly evolving integrated health systems environment. If you are not familiar with the Medicare SNF benefit, I will highlight the key eligibility requirements. First, that these patients generally require a 3-day hospital inpatient stay prior to the SNF admission. There are some exceptions to the 3-day stay requirement. For example, beneficiaries in an accountable care organization or ACO that chooses to waive the requirement, and beneficiaries subject to time-limited public health emergency waivers like the current COVID-19 PHE and during natural disasters. Second, beneficiaries require skilled nursing facility level of care. This is defined as 1, a need for daily skilled nursing and/or rehabilitation services, specifically PT, OT, and SLP. 2, the services can only be furnished on an inpatient basis in the SNF. And 3, the services must be reasonable and necessary to restore or maintain health or function. Early in my career, the definition of fee-for-service is just that. Providers furnish a range of services and were then paid based upon the cost of performing the services. When the SNF payment model changed to the RUG-based case mix-based prospective payment system in 1998, payment rates continue to be driven by the volume of therapy minutes furnished. As this slide depicts, Pdpm dramatically changed the incentives. The Center for Medicare and Medicaid Services, or CMS, replaced RUG-4 payment model with Pdpm in October 2019. When Pdpm replaced RUGs, it eliminated the linkage of payment to the volume of therapy services furnished, reducing the perceived incentives to provide unnecessary therapy services. Key points to understand about Pdpm are: 1, when the model drivers are an array of clinical data elements assessed within the first few days of the SNF stay, and 2, that these elements are also served to establish a baseline to compare outcomes of care to. Before I speak more about Pdpm, I think it's important to understand that a SNF is a unique healthcare environment, and that most beds are occupied by long-term residents who typically are over 85 years old, have multiple chronic conditions, and have mobility and/or cognitive impairments. As depicted by the blue wedge in the pie chart, the primary payer source for most of these individuals is Medicaid, accounting for nearly 2/3 of the SNF total revenues. The yellow wedge in the pie chart indicates that only 10% of SNF revenues are based on fee-for-service payments under Pdpm. The other payers in the green pie wedge include Medicare Advantage, Veterans Administration, TRICARE, commercial plans, and private pay. A side note about Medicare Advantage: these are private insurance plans that cover people eligible for Medicare Part A and Part B benefits, but who instead choose to enroll in an MA plan to manage their care. Currently, 47% of Medicare beneficiaries are enrolled in MA plans. A growing number of state Medicaid programs are also converting to privately managed care plans. In addition to Pdpm, more Medicare patient stays are also subject to some form of outcomes-based incentive models, such as ACOs. ACO networks, including physicians, hospitals, SNFs, and other provider types, are incentivized to work to improve outcomes and reduce costs of care. While they're still paid under fee-for-service payment models such as Pdpm, CMS uses risk adjustment to compare the cost of care and outcomes for similar patients, and then issues performance-based payment incentives or penalties to providers. As depicted in the pie chart on the right, a growing portion of Medicare Part A fee-for-service patients are under accountable care models, reaching 43% in January 2022. However, that is expected to change dramatically. As depicted in the text box, CMS recently announced their goal is to have all Medicare beneficiaries be in accountable care organizations by 2030. CMS is also targeting most state Medicaid programs to transition to such models. I'm sure you're seeing a trend here. By 2030, nearly all SNF services will be paid under some form of outcomes-based payment models that favor providers who can demonstrate better outcomes at a lower cost. Those SNF rehabilitation researchers that better leverage PDPM data will be better positioned to demonstrate the value of therapy services within the broader context of managed care payers, integrated healthcare systems, and accountable care organizations. In the next few slides, I'll provide a high-level overview of the PDPM payment model, data features, and data categories. First, PDPM case mix data and data for many SNF quality measures are derived from one of three types of assessments called the minimum data set, or MDS. Many of these data elements have been or are in the process of being standardized across all post-acute provider settings. As depicted in the arrow on the slide, the SNF PPS 5-day assessment will usually determine the PDPM case mix classification for the entire stay. The interim payment assessment, or IPA, can be used to adjust rates if care needs to change during the stay, if this is an optional assessment. The SNF PPS discharge assessment does not impact case mix. However, it does contain valuable outcomes related information, such as the type and amount of therapy furnished, changes in functional status, and discharge location. CMS also has other MDS assessments for all residents called OBRA assessments. These are performed at a minimum of on admission and on a quarterly basis. Additional OBRA assessments may be required with significant changes in condition. CMS expects to align the PDPM and OBRA assessment functional data and other data elements in October 2023. While other payers may not use PDPM assessments, all patients covered under these plans will still have the mandatory OBRA assessment data available for research purposes. PDPM independently determines the case mix rates for 5 separate types of services: PT, OT, SLP, nursing, and non-therapy ancillaries, such as drugs and expensive medical equipment. The total per diem rate is the sum of these components, along with a fixed non-case mix cost for room and board. There are 37 different MDS data elements used to determine the PT and OT component classification. These components use the same clinical factors. The first factor is the primary reason for SNF stay, identified by an ICD-10 diagnosis code. In some cases, the diagnosis may be combined with a type of inpatient surgery in the preceding hospital stay. This information is distilled down into 4 distinct clinical categories: 1, major joint replacement or spinal surgery; 2, other orthopedic conditions; 3, medical management conditions such as acute infections, cancer, pulmonary, cardiovascular, and blood coagulations; and finally, non-orthopedic surgeries or acute neurologic conditions. The second factor of clinical characteristics driving these component rates is the resident's function, based on the scores of mobility and self-care items in section GG of the MDS. As depicted by the red dot in the slide, combining these 2 factors results in 16 PT and OT component payment groups. There are 66 different MDS data element fields used to determine SLP component classification. In this slide, you can see the resident characteristics that reflect an increased need for SLP services. First, this component utilizes the presence of an acute neurologic condition diagnosis as a primary reason for SNF stay. The second factor is the presence of any 12 categories of comorbidities. Examples include neurological diagnoses, swallowing and communication disorders, cancers involving the airways, and tracheostomy and ventilator care. The third factor is the presence of a cognitive impairment identified by a patient interview or staff assessment. The fourth and fifth factors impacting this component are the presence of a mechanically altered diet and/or a swallowing disorder. As depicted by the green dot, the combination of these factors results in 12 total SLP component payment groups. There are 132 different MDS data element fields used to determine the PDPM nursing component classification. PDPM starts with 8 hierarchical nursing categories. 3 categories of extensive service needs, such as ventilators, tracheostomy, and isolation for infectious diseases, and 5 categories of clinical conditions. Examples: patients with higher nursing needs in these categories are those needing radiation, respiratory therapy, dialysis, and those with serious medical conditions, including septicemia, wounds, and burns. There's also a separate nursing component rate add-on for patients with HIV/AIDS. Once a base category is identified, the patient's nursing functional score and presence of depression or restorative nursing can modify the 8 categories to create 25 nursing component payment groups, as depicted by the gray dot. And now we discuss the last of the 5 case mix adjusted components, non-therapy ancillaries. 34 different MDS data element fields determine the Nta component classification. As indicated by the blue dot, this component includes 6 case mix payment groups. The way these groups are identified for a specific resident is that the CMS has developed a list of 50 conditions and types of extensive services that typically require high-cost drugs, biologic, and equipment. Each of the 50 items of the Pdpm Nta list is assigned a point value. If a resident qualifies for more than one of the items on the Nta list, all points are added up to determine which Nta case mix group the resident falls into. Examples of the highest weighted Nta component services or conditions include patients with HIV/AIDS, parenteral feeding, IV medications, ventilator or respirator, and lung transplants. Researchers may want to consider leveraging the rich Pdpm nursing and Nta component data elements as potential rehab outcomes risk adjusters. I mentioned earlier that Pdpm is based on clinical characteristics of care needs, not therapy volume. However, CMS voiced concern that SNFs could be incentivized to reduce the amount of therapy services to a level resulting in worse outcomes. Because of the CMS added policy guardrails such as capping the allowed use of concurrent and group therapy and promised increased monitoring. To monitor therapy, CMS is looking at how much therapy minutes and days were delivered by therapy discipline during the first initial 5-day PPS assessment period and during the entire stay. CMS is also monitoring trends of mode of therapy delivery, such as individual one-to-one therapy, concurrent therapy with 2 patients, or group therapy with 2 to 6 patients per therapist. The trend line in this slide is an example of what data the agency is looking at. When Pdpm started in October 2019, as depicted by the blue bubbles turning red, the average amount of therapy reported in the 5-day assessment immediately dropped nearly 30%. With such a dramatic change, CMS monitored SNF outcomes related to therapy care closely to ensure that the amount of therapy is not the same for everybody in a cookie cutter fashion, and that is appropriate for their patients' individual needs. Fortunately, so far, CMS reports that despite significant shifts in therapy delivery during the first year of Pdpm, the agency did not see significant changes in key quality metrics related to falls with major injury, pressure ulcers, hospital readmissions, or other similar quality metrics. Recently, independent academic research articles such as the Raman study chart on this slide have reported similar outcome patterns. Specifically, these researchers looked at pre and post Pdpm implementation changes in therapy minutes reported on a SNF PPS 5-day assessment and found, as depicted in the gray bars in the chart, that therapy minutes shifted to a relatively normal distribution during the first 6 months of Pdpm. The Pdpm pattern of therapy minutes is dramatically different from the pre-Pdpm pattern depicted by the black bars, where the highest peaks were just above the 500-minute and 720-minute RUG payment thresholds. Like the CMS findings depicted on the prior slide, these researchers found that the changes in therapy service delivery patterns under Pdpm did not appear to impact key clinical outcomes, including hospital readmissions, length of stay, or discharge function score. At this point, it appears that the therapy changes may reflect more of a right sizing of therapy care as CMS intended. However, much more work is needed to evaluate the impacts of Pdpm on therapy services. As I finish up this brief overview, I wanted to emphasize that as a LeaRRn Network Health System partner, AHCA NCAL is committed to support the network's scholarly efforts. Currently, we are partnering with LHS scholar Rick Black, who is investigating factors that influence functional outcomes and discharge disposition in SNFs using current Pdpm era data. We are excited about the potential long-term benefits of his approach while he uses information readily available to SNF providers at admission to explore approaches to improve rehabilitation-related care processes and outcomes. Additionally, as depicted on this slide, AHCA NCAL has several other research priorities listed on the LeaRRn website. Those that would be interested in partnering with future LHS scholars. I hope that you have found this brief presentation helpful in getting a better understanding of who AHCA NCAL is as a LeaRRn Health System partner, what the current and near future reimbursement and accountable care environment looks like, and how the SNF Pdpm payment model provides a wealth of information researchers can use to demonstrate the value of therapy services. I thank you for your time.